Hello students, today I am talking about the antifungal agents. These drugs used for superficial and deep fungal infections. For many years, Amphotericin B was the only efficacious antifungal drug available for systemic use. While highly effective in many serious infections, but it is also quite toxic. Now we'll see the antifungal drug classification. This classification is divided into five different classes. First class is the antibiotics. There are certain antibiotics which are having some antifungal activity. So these drugs comes under this category. Under the antibiotics we have two subclasses. One is polyenes, and there are very important examples: Amphotericin B, nystatin, hemicin, and netamycin. Second is the heterocyclic benzofuran. Example is grisofulvin. Second class is antimetabolites. This category of drug you already have seen in the anti-cancer chapter. Flo Cytosine. Third category is the main antifungal drugs, azoles. These azoles are again having two subclasses, imidazoles and triazoles. Imidazoles are classified here on their route of application, like topical and systemic. Topical imidazoles example are clotrimazole, iconazole, miconazole, and oxyconazole. And systemic use imidazoles are ketoconazole. Triazoles, they are systemic use triazoles. Example fluconazole, itraconazole, and voriconazole. Fourth one is allylamine. Example is terbinafine and niftyfine. Other topical agents: tolnaftate, undecylenic acid, benzoic acid, quinidochlor, cislopyroxylamine, butanafine, sodium thiosulfate. So these are the drugs comes under the classification of antifungal drugs. We'll start the first drug under the polyene antibiotic category. The drug is Amphotericin B. The structure is given here, which has distinct features on both sides of the structure. One side you can find a lot of double bonds, another side you can find a lot of OH groups. This drug obtained from Streptomyces nodosus. There is Amphotericin A as well, but that is not clinically used. Its mechanism of action is very distinct, and it has, if you see the structure of the Amphotericin B, you can find the role in the mechanism of action as well. The polyene possesses a microcyclic ring, one side of which has several conjugated double bonds and is highly lipophilic, while the other side is hydrophilic with many OH groups. You can see this thing in this structure. This side lot many OH groups are there, and this side you can find lot many double bonds are there. Okay. It is nearly insoluble in water and is therefore prepared as a colloidal suspension of Amphotericin B and sodium desoxycholate for intravenous injection. Here if you see the structure of fungus cell, there is a one outer core, outer layer, and inside there is a core where DNA, RNA synthesis is happening. And actually the drugs are also shown in this structure which are inhibiting that particular mechanism. You see the Flo Cytosine is inhibiting that synthesis. The elaboration of the section of the wall of fungi is being shown extended here. Next slide. And in this area you can see a very complicated cellular structure. So here also this lipid bilayer membrane is there. The upper layer you can find the proteins, then lipids, glycolipids. Here very important thing what is need to understand this particular mechanism where squalene is converted into squalene epoxide and it converts into lanosterol. This lanosterol by multiple pathways or processes it converts into ergosterol. Ergosterol which takes part in the development of this cell wall of the fungi. Here you can see the Amphotericin B and nystatin inhibiting the incorporation of the ergosterol. Azoles are also playing a role while converting lanosterol into ergosterol. Even terbinafine, which you will see in the next slide, the squalene, they block the conversion of squalene into squalene epoxide. So just remember this diagram, which will help you out to understand the mechanism. Amphotericin B is selective in its fungicidal effect because it exploits the difference in lipid composition of fungal and mammalian cell membrane. Ergosterol, a cell membrane sterol, is found in the cell membrane of fungi, whereas the predominant sterol of bacteria and human cell is cholesterol. That is why these drugs are comparatively safe for the host because their affinity towards very specific ergosterol for fungi. Amphotericin B binds to ergosterol and alters the permeability of the cell by forming amphotericin B associated pores in the cell membrane. So actually it is making the cell wall of the fungus more porous, and because of that the leakage of the cell material happens, which will ultimately leads the result as a cell lysis. As suggested by its chemistry, amphotericin B combines widely with lipids, ergosterol, along the double bond rich side of its structure and associates with water molecule along the hydroxyl rich side. Remember here the cholesterol structure resembles with the structure of ergosterol, and here why these drugs are not much active against bacteria, because bacteria do not have sterols, so unaffected by the polyenes. By this amphipathic characteristic, several polyene molecules together orient themselves in such a way as to form a micropore. The hydrophilic side forms the interior of the pore through which ions, amino acids and other water soluble substances move out. The micropore is stabilized by membrane sterols which fills up the space between the amphotericin B molecule on the lipophilic side constituting the other surface of the pore. So like that this molecule makes a pore into the cell wall and changes the permeability, and so the leakage happens. So the pore allows the leakage of intracellular ions and macromolecule, eventually leading to cell death. Some binding to human membrane sterols does occur, probably accounting for the drug's prominent toxicity. So as I told you, actually it is not meant to bind with that, but in higher doses, some of the membrane sterols it targets and binds with the mammalian sterols. So some kind of toxicity is also appearing. Resistant to amphotericin B occurs if ergosterol binding is impaired, either by decreasing the membrane concentration of ergosterol or by modifying the sterol target molecule to reduce its affinity for the drug. Amphotericin B is active against a wide range of yeasts and fungi as Candida albicans, Histoplasma capsulatum, Cryptococcus neoformans, Blastomyces dermatitis, Coccidioides immitis, Torulopus Reudotorula, Aspergillus, Sporothrix, etc. Fungicidal at high and static at low concentration. Here it is important to discuss few points about the pharmacokinetic of amphotericin B, which has been observed like primarily on intravenous. It's an intravenous drug. It has a less absorption from GIT, 90% protein bound, and T half is around 24 hours. One more important point here about the amphotericin B is this drug concentration in pleural fluid. It concentrates in pleural fluid, peritoneal fluid, synovial fluid, aqueous humor, and vitreous humor. Approach 2/3 of the serum concentration when local inflammation is present. So now we'll see what are the uses of amphotericin B. Amphotericin B can be applied topically or oral, vaginal and cutaneous candidiasis and automycosis. Also, it is useful in systemic mycosis and is the gold standard of antifungal therapy. Because of its higher toxicity of this drug, the azole antifungals are now preferred in conditions where their efficacy approaches that of amphotericin B. Leishmaniasis. One more use of the amphotericin B is towards leishmaniasis. Its most effective drug for the resistant cases of Kala Azar and mucocutaneous leishmaniasis. To treat the serious disseminated yeast and dimorphic fungal infections in immunocompromised hospitalized patients, it is also very much used. Preferred drug for the unstable neutropenic patients with Candida albicans fungemia. For AIDS patients with moderate to severe cryptococcal meningitis, amphotericin B preferred over fluconazole in initial treatment. Later, fluconazole is daily oral dose is preferred. For the AIDS patients with the disseminated histoplasmosis, amphotericin B for initial therapy, and then later itraconazole oral daily dose preferred, with the intermittent dose of Amphotericin B for chronic infections. Drug of choice for invasive aspergillosis, locally invasive mucormycosis, many infections of immunocompromised patients. So these are very potential uses. Now we'll see the ADR. The toxicity of Amphotericin B can be divided into two broad categories: immediate reactions, which are related to the infusions of the drug, and those occurring more slowly. First, we'll see the infusion related toxicity. Infusion related reactions are nearly universal and consist of fever, chills, muscle spasm, vomiting, headache, and hypotension, and dyspnea lasting for 2 to 4 hours, probably due to release of cytokines. They can be ameliorated by slowing the infusion rate or decreasing the daily dose. It means if these reactions are more or you want to subside it, then infusion rate can be controlled as well as the dose can be reduced. Pre-medication with antipyretics and antihistaminics, mepridine or corticosteroids can also be helpful. Now the cumulative toxicity. Renal damage is the most significant toxic reaction observed with this drug. Renal impairment occurs in nearly all patients treated with clinically significant doses of amphotericin. The degree of azotemia is variable and often stabilizes during therapy. One reversible decrease has also been seen for the renal perfusion. An irreversible renal tubular injury and subsequent dysfunction. The irreversible nephrotoxicity usually occurs in the setting of prolonged administration, more than 4 gram cumulative doses. It has some minor CNS toxicities as well, but it's only happening when intrathecal injection given. Headache, vomiting, nerve palsies, etc. If we talk about the doses of the Amphotericin B, so intestinal, in case of intestinal moniliasis, orally 50 to 100 mg QID can be given. In case of vaginitis and otomycosis, topically 3% eardrops given. In case of systemic mycosis, 1 mg IV test dose followed by 0.3 mg per kg infused over 4 to 8 hours. There are certain interactions observed with this drug. Flo Cytosine has supraadditive action with AMB in the case of fungi sensitive to both. So if any fungus which is sensitive for both, Flo Cytosine can be combined with this drug to make a supraadditive combination. Rifampin and minocycline potentiates AMB action. So this was about the Amphotericin B. Now we'll talk the second category of drug, azoles. Here we'll discuss about imidazoles and triazoles. They are the synthetic compounds with the broad antifungal spectrum, exerts antifungal activity by binding to cytochrome P450 enzyme, responsible for the demethylation of linosterol to ergosterol. Already we have discussed about it. Reduced fungal membrane ergosterol concentration results in damaged leaky cell membranes. Triazoles have fewer side effects, better absorption, better distribution, and fewer drug interaction. Here the two azoles most commonly used, clotrimazole and miconazole, while ketoconazole is used both orally and topically. Two triazoles, fluconazole and itraconazole, have largely replaced ketoconazole for systemic mycosis because of greater efficacy, longer T-half, fewer side effects, and drug interactions. If you see the mechanism of fluconazole, The mechanism of action of imidazole and triazole is the same. They inhibit the fungal cytochrome P450 enzyme, lenosterol 1,4-dimethylase, and thus impair ergosterol synthesis, leading to a cascade of membrane abnormalities in the fungus. So you remember the diagram what I have shown you initially, the cell wall structure of the fungi and how the inhibition of the lipid form to incorporate into the cell wall disrupts the cell wall. The lower host toxicity of triazoles compared to imidazoles has correlated with their lower affinity for mammalian CYP450 enzyme and lesser propensity to inhibit mammalian sterol synthesis. So this is the reason why the mammalian sterol synthesis is not inhibited by these drugs, and it's quite safe for them. In this category, there is a one drug which is a quite used drug, clotrimazole, maybe well known to you. It is effective in the topical treatment of tinea infections like ringworm, where we can give 60 to 100% cure rates reported with 2 to 4 weeks application on a twice daily schedule. Athlete's foot, otomycosis and oral cutaneous vaginal candidiasis have response in more than 80% cases. It is particularly favored for vaginitis because of a long-lasting residual effect after once daily application. A 7-day course is generally used. For oropharyngeal candidiasis, 10 mg troche of clotrimazole is allowed to dissolve in the mouth 3 to 4 times a day, or the lotion gel is applied, swirled in the mouth for as long as possible. It is also effective in skin infections caused by Corin bacteria. Okay, so we'll move to the next the main category of the antifungal drugs, that is fluconazole. Fluconazole, if you see its ADME, you'll observe it is 80 to 90% orally administered drug, absorbed and giving high serum drug level. T half is around 27 to 37 hours, permitting once daily dosing in normal renal functions. Only 11% of circulating dose is bound to plasma proteins. Including normal and inflamed meninges, it has wide penetration to tissues. CSF level are 60 to 80% of serum levels. That's why you can understand they are very much used for the fungal meningitis. 80% excreted unchanged in urine and 10% in feces. Here the certain indications of fluconazole as cryptococcal meningitis, systemic and mucosal candidiasis in both normal and immunocompromised patients, coccidiodal meningitis and histoplasmosis. There are some potential ADR of fluconazole. Some side effects, some fewer side effects like nausea, vomiting, abnormal pain, rashes and headache are there. And because of the selectivity for fungal cytochrome P450 is higher, unlike ketoconazole, it does not inhibit steroid synthesis in man. Anti-androgenic and other endocrine side effects have not occurred. Elevation of hepatic transaminase has been noted in AIDS patients. It is not recommended in pregnant and lactating mothers. There are some very important interactions of this drug. Because of fewer hepatic enzyme interactions and better GI tolerance, fluconazole has the widest therapeutic index of the azoles. Though it affects hepatic drug metabolism to a lesser extent than ketoconazole, its increasing plasma level of phenytoin, estimizole, cisapride, cyclosporin, warfarin, zidovudine, and sulfonylureas. So you can understand well that if this drug is increasing the plasma level of these drugs, it means it is going to cause serious toxicities. A few cases of ventricular tachycardia also been reported when fluconazole given with the cisapride. The same caution as with ketoconazole or itraconazole need to be applied in co-administering other drugs. H2 blockers and proton pump inhibitors do not affect its absorption. Now we'll see some of the clinical uses of fluconazole. A single 150 mg oral dose can cure vaginal candidiasis with few relapses. Oral fluconazole is highly effective in oropharyngeal candidiasis. AIDS patient with esophageal candidiasis responds to fluconazole. Single 150 mg dose effective in vaginal candidiasis. Successful treatment can be given for Candida endophthalmitis. It is also used in the stable non-neutropenic patients with candidemia treated with fluconazole. Unstable immunocompromised patients should initially receive Amphotericin B. It is an alternative to Amphotericin B for initial treatment of mild cryptococcal meningitis. It is found better than an Amphotericin B for long-term preventions of relapsing meningitis, but in this case, the lifelong treatment required. It is used in the coccidiodal meningitis, where it responds to oral prolonged doses of fluconazole. In the case of coccidiodal meningitis, earlier amphotericin B was the main drug to use. Tinea infections and cutaneous candidiasis treated with 150 mg weekly fluconazole for 4-week treatment. Aspergillosis, mucormycosis, pseudoalicariosis. These are not responding well to fluconazole. Sporotrichosis, histoplasmosis, and blastomycosis are better treated with itraconazole. This drug can be used in the prophylactic treatment for deep-seated mycosis infections in bone marrow transplant recipients. Prophylactically used in end-stage AIDS patient for cryptococcal meningitis, esophageal candidiasis, and superficial fungal infections. There are certain ADRs of fluconazole. Nausea, vomiting, abdominal pain, rashes, and headache. Asymptomatic liver enzyme elevation also there. Drug associated hepatic necrosis also reported. In prolonged doses therapy, alopecia is the one reported ADR. It increases level of phenytoin if co-administered. Okay, so now we will discuss about the next drug, that is Flo Cytosine. This drug was discovered in 1957 during a search for novel antineoplastic agent. This is a fluorinated pyrimidine analog of cytosine. You remember that 5-fluocytine is converted to 5-fluorouracil inside the cell by the enzyme cytosine deaminase. Flucytosine is a water-soluble pyrimidine analog related to chemotherapeutic agent 5-fluorouracil. Its spectrum of action is much narrower than that of amphotericin B. Flucytosine is currently available in North America only in an oral formulation. It's not used in India. The dosage is 100 to 150 mg per kg per day in patients with normal renal functions. It is well absorbed with serum concentrations peaking 1 to 2 hours after an oral dose. It is poorly protein bound and penetrates well into all body fluid compartments, including the cerebrospinal fluid. It is eliminated by glomerular filtration with a half-life of 3 to 4 hours and is removed by hemodialysis. Levels rise rapidly with renal impairment and can lead to toxicity. Toxicity is more likely to occur in AIDS patients and those with the renal insufficiency. So what is the mechanism of Flo Cytosine? When it is taken up by a fungal cell via the enzyme cytosine permease, it is converted intracellularly first to 5-FU and then to 5-fluorodeoxyuridine monophosphate 5-DUMP and fluorouridine triphosphate, which inhibit DNA and RNA synthesis respectively. To understand this mechanism, you can refer again the anti-cancer drugs where 5-fluorouracil mechanism has been explained. Human cells are unable to convert the parent drug to its active metabolite, resulting in selective toxicity. This is the reason it is quite safe for the human. Resistance is thought to be mediated through altered metabolism of flucytosine, and though uncommon in primary isolates, it develops rapidly in the course of flucytosine monotherapy. So it decreases fungal cell membrane permeability, and the decreases when the level of fungal cytosine deaminase decreases, then both the cases resistance develops. Amphotericin B and 5-fluorouracil is a very good treatment option for the cryptococcal meningitis and deep-seated candida infections as septic arthritis and meningitis. The spectrum of activity of flucytosine is restricted to neoformans, some candida species, and the dematicaceous molds that cause chromoblastomycosis. This drug used in combination therapy either with amphotericin B or with cryptococcal meningitis, B for the cryptococcal meningitis, or with itraconazole for chromoblastomycosis, provides enhanced penetration of the flucytosine through amphotericin damaged fungal cell membrane. So if you combine these two drugs, the reach of this drug increases into the membrane. So there are some important ADRs. The adverse effects of flucytosine results from metabolism to the toxic antineoplastic compound fluorouracil. So when it converts into fluorouracil, the toxicity is the same fluorouracil kind of toxicities are appearing. Bone marrow toxicity with anemia, leukopenia, thrombocytopenia are the most common adverse effects, with the arrangement of liver enzyme occurring less frequently. A form of toxic enterocolitis can occur. There seems to be a narrow therapeutic window with an increased risk of toxicity at higher drug level and resistance developing rapidly at subtherapeutic concentrations. Okay, now after this 5FC, we will talk about the topical L-alanine. This is the last category of drug what we are discussing here. Terbinafine and neftifine are L-alanine available as topical creams. Both are effective for treatment of tinea cruris and tinea corporis. Terbinafine is orally and topically active drug against dermatophytes, and Candida belongs to a new L-alanine class of antifungals. It acts as a non-competitive inhibitor of squalene epoxidase, an early step enzyme in ergosterol biosynthesis by fungi. Just to understand this, please go back and see the structure of cell wall. There itself it has been shown where this particular drug is blocking the action, blocking the mechanism. Accumulation of squalene within fungal cell appears to be responsible for the fungicidal action. The mammalian enzyme is inhibited only by 1000-fold higher concentration of terbinafine. That's why it is quite safe for the humans. If you see the side effects, there are certain side effects of terbinafine observed, like gastric upset, rashes, taste disturbances, some cases of hepatic dysfunction, hematological disorders, and severe cutaneous reactions are reported. Enzyme inducers lower and enzyme inhibitors raises its steady state plasma level. It's an important point. This point will help you out to write the interaction of this drug. Terbinafine does not inhibit CYP450. Topical terbinafine can cause erythema, itching, dryness, irritation, urticaria, and rashes. Use terbinafine applied topically as 1% cream or orally 250 mg OD is indicated in tinea pedis, corporis, cruris, capitis, and Tariasis versicolor. 2 to 6 week treatment is required according to the site. Onychomycosis is treated by 3 to 12 months oral therapy. Efficacy in toenail infection is 60 to 80%, which is higher than glycofulvin and itraconazole. So students, here some of the important drugs we have covered. Now there are certain more drugs which you need to be covered by you as an assignment. So you have to write the pharmacology of the following drugs: nystatin, glycofulvin, ketoconazole, itraconazole, tolnaftate, cislopyroxylamine, and quinidochlor. These are the references what I have used here. Katzung, K.D. Tripathi, and Goodman-Gilman used mainly. Thank you all for listening this video. Thank you.